Hello and welcome to Health Talk here on AETVLIVE. I am Gaga Ekama and I'm your host. In case you are joining us for the first time and you are wondering what Health Talk is all about, I'll tell you, Health Talk is that program where I get to dissect with a health practitioner health-related topics. On today's episode of Health Talk, I am bringing back a guest, like I promised before, a guest which was here with me, and we discussed sexually transmitted infections and we majored on gonorrhea. Today, we will be looking at HIV. He is no other than Dr. Nnamdi Ekwe, an ART clinician. Hello, Doc. It's good to have you back yet again. Welcome.
Thank you.
Okay, so today, of course, the last time you came, we talked about sexually transmitted infections, the STIs, and we majored on gonorrhea. I told you then that I was going to have you back so we can look at HIV because we cannot talk about STIs and not talk about HIV. So thank you for obliging me.
Thank you.
All right, so HIV, what does that mean?
Okay.
I know it's an acronym.
That's okay.
Yes.
Just like what you said, HIV, it's a human immunodeficiency virus, HIV.
Okay.
That's what it simply means.
So now it tells us it's a virus. So
It's a virus.
what does this virus do to the human body?
Yes, it's a virus that when introduced, it affects immunity. That's a specialty. It goes for the immunity, the host immunity, and then it destroys immunity, giving rise to other infections. Other infections that may come up, what they call maybe opportunistic infections, to come up. And these infections itself begin to destroy the host. Actually, the virus is living its life, and it's doing its best to survive. So it's the way your body fights to it, the body handles it. It destroys the immunity, and then other infections will take over the body and then destroys the body.
Okay. Now, most times HIV goes with HIV/AIDS. HIV/AIDS. Now, what is the difference between HIV and AIDS, or is it just one name? And so, someone wondering, like, why did he just call it HIV? Because so I believe some people call it HIV/AIDS. HIV/AIDS. So, what's the difference? What's the relationship?
There's a big difference between HIV and AIDS. HIV is the human immunodeficiency virus. AIDS itself is the acquired immunodeficiency syndrome, complex of broad complex of disease itself. Now, HIV leads to AIDS.
Oh.
HIV leads to
Just
AIDS.
like you said in the last episode that
Exactly.
STIs lead to STDs.
Exactly.
Okay.
HIV leads to AIDS. So, just like what you're saying, we talked about infections and diseases. You can see the HIV itself comes as an infection because most of the time the patient is infected and he doesn't know. Then when he start having where he can't even handle things again now, AIDS defining. So most of the time HIV leads to AIDS. So I still sometimes I wonder why people say HIV/AIDS. They do confuse
Okay,
the
you
two.
heard it too, right?
I've heard that they do confuse the two. They also confuse me. HIV is not AIDS. HIV leads to AIDS. They're
Okay.
two different things.
Thank you for that clarity. Now, what is the cause of HIV?
Okay, HIV itself is a virus. What do you mean is,
Apparently.
what is the cause of HIV infection?
Okay.
HIV itself is a virus, it's a lentivirus.
Okay.
And this virus, it's been so troublesome for years. Discovered in Nigeria in 1984. It has been there, and this virus mutates. Now, the virus itself is a sexually transmissible infection, like I said. It can move through blood and blood products, like, for instance, we have blood transfusion. It could go through fluids, seminal fluids, vaginal fluids, saliva, it moves. That's a virus. It's very wonderful. It's quick to multiply. It's very quick to multiply. And one peculiar thing about the virus is that it mutates. Now, when the virus replicates means it gives birth to more. When it gives birth to more, it doesn't give birth to the same structure, the same
variation,
morphology. Yes, there's a variation. So the morphologies are different. So that is why scientists are finding it difficult to get a cure to the virus, because definitely the virus produces A today, this kind of A today, tomorrow is producing Z, more of D tomorrow. You can't predict it. So that's one peculiar thing about the virus itself.
Yeah, so when I asked you about the cause, you kind of touched on the modes of transmission. And in as much as you said it's a sexually transmitted infection, you also mentioned that it can be transmitted via blood transmission.
Okay.
Yes, and saliva. So these are acts that can be independent of sexual intercourse. So it means that it's not only transmitted via sexual intercourse.
Yes, it's not. Even breastfeeding.
Even breastfeeding.
Even breastfeeding.
If a nursing mother is positive,
yes, she can infect the baby.
Fluids. Okay, so just give us a general rundown of the modes of transmission. Breastfeeding.
Okay, I said breastfeeding. I said fluids, such as I said vaginal fluids. I mentioned seminal fluids. I mentioned what else? What do you have there?
You said blood transmission.
Blood transfusion. Yes, I also said even saliva.
Yeah.
They can chew all these means.
Oh.
Right.
Okay. So now, after transmission, how can one know if he's a carrier or she is a carrier of the virus? The symptoms.
All right. HIV itself, HIV infection does not have symptoms.
Are you serious?
Initially, there are no symptoms. Patient can even have that. There are people that live with HIV for 5 years, 3 years, 5 years, 2 years. They don't get infected, no symptoms whatsoever. That is why we encourage people to go do testing, to go test. Because yes, stage 1 of HIV is asymptomatic. The patient is fine. Doesn't know he has an infection.
So now you've talked about no symptoms and you talked about stages. So it also means there are stages of HIV.
Yes. The WHO staging of HIV classified into 4 stages.
Okay.
And then the first stage is asymptomatic, like I said, no symptoms whatsoever. They may have what they call persistent generalized lymphadenopathy, which means what we call lymph nodes, those things that fight against infection in the body. Just like somebody that falls and then he notices there's a swelling on the groin with time. Those things are lymph nodes. So it has this persistent generalized lymphadenopathy. It may be multiple, maybe everywhere. It may mostly be maybe in the mandibles or the maxilla, just here. The armpits would swell, But
these are symptoms in stage 2?
Yeah, stage 1.
Stage
stage 1. It may be noticed.
Okay.
But most of the time, stage 1 is asymptomatic. While stage 2, the major problem with stage 2 is that the person begins to lose weight. He tells you he has lost 10% of his body weight. Let's say, for instance, he weighs 70 kg. He loses 10%. He loses 7 kg. Let's say he starts weighing 63, or maybe 64, or maybe 65. Something is going on. Something is wrong, He may go on to have what they call pruritic papular rashes. Those are rashes that come out, they erupt, and they are so itchy.
Is this stage 2 or stage 3 now?
Yeah, stage 2 now.
Wow.
They are so itchy. These rashes, most of the time, they have them at the back, they have them on the arms, they have them on the chest, in the face sometimes. They're so itchy. So this patient feels uncomfortable. So that's one. Then the patient may have what they call herpes zoster infection. Herpes zoster is a viral infection. Like I told you, the HIV creates a medium, a pathway for other infections to start manifesting. It's not as if the HIV itself is just in its own part. So herpes zoster infection, it's a viral infection that follows dermatomes. When I say dermatomes, it follows the nerve and the nerve itself, the course of the nerve. You can follow the course of the nerve. You can find it at the back. It goes in a straight line. You can find it on the face. You can find it on the side of the ear. But the peculiar thing about this herpes zoster infection is that it's burning. It's burning. It could be painful.
So anywhere it's found, it gives a burning sensation.
Burning, painful sensation. The patient can't even, he will look at you, he can't touch it. It's painful and burning at the same time. Itches too. So it's peculiar when you see that, you say, person is maybe have HIV. Although there are people with that infection and then don't have the HIV. But then it comes, once the person has HIV, he may have that.
Okay.
Now,
Stage 3.
Stage 3. In stage 3, now this patient start having diarrhea, watery stool, passing watery stools, and complain of fever once in a while, And then this diarrhea, persistent stooling, leads to him losing weight more.
More weight.
Now, like I said, stage 2 is less than 10%. Stage 3 now will be more than 10%. You can see maybe he's weighing 70, start weighing 60, 50. See him looking cachetic, losing weight. So that's one peculiar thing. Then tuberculosis has, and HIV, they are like man and woman, they're very close. TB comes at stage 3. So most of the time when the patient comes in with tuberculosis, I know the patient is in stage 3. So TB is very common for HIV. What they call oral candidiasis. You've noticed inside the mouth is whitish. Sometimes you complain of the vagina as whitish, She may complain the vagina is whitish. That's you're thinking of stage 3. Stage 4, that is where you're not calling AIDS-defining illnesses. AIDS-defining illnesses.
Okay.
You now see, I got into stage 4. I've entered AIDS. AIDS-defining illnesses. And it gives rise to most opportunistic infections. Like I said, the immunity is low. These opportunistic infections come out. What they call pneumocystic carrier pneumonia comes out. Cryptococcus comes out. Histoplasmosis. Toxoplasmosis. There are many. These infections just line up that way.
For just one person, because of
this
you may HIV infection.
Yes, you may have one, you may have two, you have all of them.
Okay.
So that's the thing.
Okay. Now, what are the risk factors? Because you've told us about the, talking about the stages, you've touched the symptoms. So what are the risk factors? What exposes one to this HIV infection, to this virus?
Well, I'm going to be realistic. I want to be realistic about this thing. The books will tell you sexually transmissible infection. Books will tell you sharing of sharp objects, maybe toothbrush that is sharp, or somebody drops a toothbrush and then he brushes with that thing and then he gets the infection. In saloons, sharing of sharps, like I said initially. Blood products too. For instance, blood transfusion. You have a blood with HIV infection inside it. You just stay there and wait, then the person gets transfused and gets it. Mostly introduction. There's an introduction of the virus into the system. Maybe a cut, maybe an accident victim. Now, I'm just being realistic now. When you speak with people that had infection, they will tell you they don't know how to got it. Most of them don't know how to got it. It's most of the time you can't really decipher. But you could just know that if this person has this unsafe practices, is involved in unsafe practices, maybe he shares needles, they mentioned that, sharing of needles, he takes drugs, shares needles, this person gives, transfer to that person, person takes it too, he's maybe on what they call MSMs, men that sleep with men, practices, bad practices that I don't know how to describe it, but what I'm trying to say here in essence is that such patients, such people become infected as a result of one or two objects that prick them. You know my point. It can be transmitted also to babies. If the mother is positive, the mother is infected, she can give it to the baby. Because she didn't take her drugs, or maybe she's not aware, the baby may end up having it. It can go through the birth canal. So you can see there are lots and lots of ways that
Let me ask you a question. A mother who is positive, a carrier, and probably she doesn't know,
Okay.
and she takes in during that period, can the child be born positive?
Yes, depending on the viral load of this patient, what they call the viral load of the patient. Viral load means I'm talking about the amount of copies of this virus. We call them copies, viral copies per mil in that patient. Now, if it is much and overwhelming, the baby will end up having it.
Okay. Okay. So now, I don't know if you have touched the diagnosis or you haven't, how it can be the diagnosis of this.
Yes, recently we started the process of test and treats. We started giving out strips. We encourage youths to go to the hospitals and have themselves tested.
Now, how often should someone go for these tests?
I mean,
You
you
think-
can do the strips. I think is free. It's free. So I think doing it monthly, maybe doing monthly or 2 monthly, not bad. 3 monthly, wouldn't be bad. Let's say if someone does it 3 times a year, 4 times a year, that won't be bad. Because
Okay.
actually, there's a window period where the patient might be infected, he does the test, it's negative.
So what's the duration of this window period?
This window period, like I said before, 1 month, 1 to 2 months, patient will not know, may not know that he's infected. You see my point?
Okay.
Yes,
So it's not bad if someone does that quarterly.
quarterly.
Yes, go for your test quarterly. So you're talking about the strips, the diagnosis. Yes.
Yes, the strips. So, like I said before, the strips, the government has made it possible for strips to be available in most facilities, in most laboratory. All you need to do is just move in there. It's free. Like, you move in there, you want to do HIV test. They take a sample, and then result comes out. Voila, 5 minutes stops. You see your result.
So-
And recently, there's what they call the self-testing kits. But these self-testing kits, we give it to partners. For instance, a couple that want to get married, or maybe they just want to test themselves. You don't have to prick yourself with a self-testing kit. All you need to do is just put it in your mouth, rub it in your mouth,
Are you
go
saying?
round. Yes, it's a new improvement.
Mm.
Rub it round the mucosa lining here. Then drop the strip, give it 5 minutes. It shows 5 minutes, 2 lines positive, 1 line negative.
That's a.
So we've improved. We've improved.
Well, okay. So now, is there hope for someone who has contracted this virus? Because earlier while we were talking, you mentioned that there is no cure.
All right, yeah.
So, but before we talk about treatment, let's talk prevention. For someone
Okay.
who is not yet a carrier of the virus, what practices? I think you call them safe practices.
Safe practices.
Yes.
Okay. We always say abstinence is a form of protection. It's the best form of protection. If you must do use condom. But then, safe practices, I mean, like I said, there must be awareness. The problem is enlightenment. There's no good knowledge of what's going on in the society. A lot of people are now aware of even HIV. A lot of people are now aware of HIV.
I must confess that the awareness of HIV has really dwindled, probably because of the pandemic. But there was a time that HIV was given major
True.
attention.
True.
Yeah.
True. There's been the COVID pandemic has created a distraction, kind of. But we, as ART clinicians and
Yeah.
the NGO we work for, we do all we can to make people realize that, hey, in as much as COVID, there's HIV.
Yeah. Still very much around.
Don't be careful. There's HIV, there's COVID. Get tested. So, like I said before,
Awareness.
awareness is one. I talked about education, like I said before, sex education is also one. Safe practices, use of condoms, barrier methods, use of condoms, use of femidoms, and all that. If I thought the patient must be intercourse. No sharing of sharp objects at all. We don't expect you to share sharp objects. I mean, I use a shaving stick. I use it, I should dispose of it. Or when I keep it around and then someone else picks it up and uses it, I'm actually exposing that person. The person may actually get infected if the person has HIV. The index person had HIV. Then,
sorry, concerning the sharp objects,
okay.
I don't know if this is a myth or it's a fact. I heard that the virus does not live long on sharp objects. I can't remember whether a duration of 3 to 6 minutes or thereabouts.
It's up to 5
How
minutes.
true is this?
It's true. It's this virus don't stay long. They can't
Outside
live outside the host environment. You know, it needs the cellular fluids to survive. So when it's outside, say 3 to 5 minutes, it dies.
Okay.
It dies. That's the truth. So
Yeah. So proceed. You were talking about don't share sharp objects. We're still talking about safe practice.
yeah. I know where I know where we're heading to. Sharp objects. How?
Yeah.
You use a sharp and then you keep it. But don't forget that you're dealing with blood here. And this blood you may have produced has cells. The virus is in the cell. The cells are in the fluid that makes up the blood. So the blood can still stay for a while. You get my point?
That's it.
Yeah, it can still stay for a while till maybe it begins to disintegrate, the cells start breaking up and exposes the virus. The virus gets exposed, then it also dies. So using sharps and then keeping the sharps, you're actually predisposing someone else. There are other practices that could we should think of. Okay, I noticed recently a group of people that had infection, HIV infection, from their barber, from their barbing salon. They all shared it. And also have inmates, prison inmates who were shaved and so they got infected. You know, these things have been happening. Those practices do happen because of poor awareness. People are not really aware. Because if you're actually aware that I could infect somebody with a needle, with a razor blade, why would I want to give it to another person? Why would I want to use it to another person? The same point. Get my point. I said awareness is also another thing. So I think basically that's it.
You said fluids now, and you also mentioned saliva. Can the virus be transmitted via kissing?
Well, when we're in school, they say saliva, viruses, the HIV itself cannot be transmitted through kissing.
I heard
That's
that
what
also.
we were taught.
Yes.
Now, what if that individual has a wound in his mouth?
Okay.
You get? Now, he introduces it, the saliva touches on the mucosal membrane, maybe it's open, the virus can start spreading from there because it's actually everywhere. It goes everywhere. It's in the sanctuary sites, it's in the saliva, it's in every fluid you can think of. It's there. So maybe the other person who's the receiver of the kiss could have an injury. Then that's from there.
Okay. So now, let's talk treatment. So I was asking, just talking about prevention. For someone who has contracted this virus, is there hope?
Yes, there's a lot of hope. I mean, you need to see them. My patients are wonderful. I mean, that is why we say test and start. A lot of people don't know they're living with HIV. That's the truth. We're working towards ensuring that 95% of the populace are aware of their status. This 95% are receiving treatment. This 95% are virally suppressed. At least 95% of them are virally suppressed. And they're using the slogan, undetectable equals to untransmissible. Undetectable equals to untransmissible. Meaning, I don't find the virus if I do a test after taking drugs for a period of time. It's not there, means I can't infect. So the reason why we encourage people to take drugs is because somehow this is a form of cure.
It suppresses the viral
Yes,
load.
but minimally. In fact, the drugs they've produced now are wonderful drugs. In 12 weeks, in 12 months, in 3 months, I can confidently tell you that this patient is as good as normal. He looks normal. The virus is very minimal in him. So we encourage people. It's just the problem is the stigma, the fear. You know, you'll be discriminated. But in the Western world, we don't really do that. We encourage people to go on to test. As long as they test, you know your status, you start treatment immediately. So that you don't tilt into AIDS, like we said. And when you get to AIDS, that is where there's a problem.
Okay, so to manage it in AIDS is much more.
It's much more difficult. I guess
Challenging.
it's challenging because actually the CD4 cells, the cells that fight for you, are depleted. And once they're depleted, the opportunistic infections act and then they destroy the person.
Okay.
Right.
So finally, even as we round off, your advice.
Yeah, like my advice is, I think it'd be wise if everyone gets tested. I'm very sure we will have a HIV-free Nigeria with time if all of us get tested, and then those who are tested, who are positive, are on treatment.
Okay. So there's hope for.
There's hope for humanity.
All right. Thank you very
thank you.
much, Dr. Nnamdi
Yes.
Ekwe. All right. Thank you very much for sticking around. I know you have learned something. Until next time, do well to abstain. And if you cannot abstain, do well to always apply the barrier method. Use your condom. Use a condom. And if you have gone for your test and you tested positive, of course, there's hope for you. Like the doctor said, do well to get the necessary medication. Until next time, do stay healthy. I am Gaga Ekama saying thank you for watching. Hello and welcome to Health Talk here on AETVLIVE. I am Gaga Ekama. As you already know, Health Talk is your #1 program where you get informed and educated on health-related matters. Today, I've got a medical lab scientist here with me, the person of Sophia Ubeide. Hello.
Hi.
Welcome.
Thank you.
It's good to have you on the show. Okay, so today's topic is something I've been looking forward to discussing. Like I was telling you offset, I once upon a time had a public health specialist, and I told the person I wanted us to talk on this, and the person told me that the best fit for this is a lab scientist. So that's why I'm bringing you on to talk about this, because it's your field actually. And what are we talking about today? We're talking about blood group and resource factor. Blood group and resource factor. So now let me begin by asking you, what is blood group?
Thank you for that question. Before I go straight into what a blood group is, you have to know what blood is.
Okay.
The blood is a bodily fluid that contains red blood cells, white blood cells, platelets, and plasma. And each of these functions, each of these parameters have their functions in the blood group. So, moving straight ahead to what a blood group is. A blood group is an entire blood group system comprising of red blood cells, which have antigens specific to some genes, and they have similar alleles or linked chromosomes.
Similar what?
Alleles. They are like genes, 2 or more genes responsible for characteristics.
Okay.
Yes.
Okay. So that's what a blood group is.
Yeah.
So now, what is a resource factor?
Fine. A resource factor is an antigen
Okay.
that is found on red blood cells. They are mostly found in humans and some primates.
Okay.
80% of the population have resource factor.
Okay. So you're telling me that not all humans that have blood have resource factors.
Yes.
Okay. So now, what is the relationship, the link between the resource factor and the blood group?
Okay. Earlier I was supposed to mention that the blood group, there are different types.
Okay.
So the resource factor is more connected to the ABO blood group.
Okay.
Yes. So, and the connection between that ABO blood group and the resource factor is that the resource factor determines if an individual is positive or negative, has a positive or negative
Blood group.
ABO blood group, basically. So it's the determining factor for the ABO blood group.
Okay, so you talked about having different blood groups.
Yes.
So bloods are grouped in different.
Yes, we have blood groups, different blood group systems.
Okay, different blood group system.
Yes.
So is the resource factor now unique to the ABO blood group system?
Yes, it's actually specific to it.
Okay, only the AB.
Yes.
Okay, now since we've delved into different blood groups, can you tell us the different blood groups?
Okay, we have different blood group systems. I'm going to name them. We have the ABO blood group, which is the most important blood group system. Then we have the Rhesus blood group system. That's where the from the Rhesus factor, that's where the Rhesus blood group system was coming from.
Oh,
So, and that one is the second most important or significant blood group we have. Then
Okay.
we have others which are rare, but it's not as if they don't exist. We have namely the KEL system. We have the KID system.
kid?
KID with double D.
Okay.
Yeah. KID system. We have the Duffy system. We have the Lieutenant system. We have the Bombay group.
Are these names of sciences or
Yes,
what?
they are names of people. Like the Bombay group,
Yeah.
it was named after a particular set of people in India, the Marathanian speaking people
Okay.
of India.
Okay. So since they were the one that came
Yes,
about this
yes,
system, so it was named after
Named
them.
After them.
Okay, I get it now. So now you said something that the ABO is the most significant of the blood group systems. Why?
Yes, because it's in the ABO blood group. In most of it contains like the population of people that have the ABO blood group are about 90%
Oh.
of the population that have it. So you rarely see those other blood group systems. They are actually very rare.
Okay. So now let's look at the characteristics of the two most significant ones you mentioned. You said the ABO and the Rhesus. So what are the characteristics?
Well, I will not really say characteristics. There are things that determine why this is ABO blood group and why this is the Rhesus blood group. They have the genes, they have the antigens and the antibodies.
Okay. The genes, antigens, and antibodies. Okay. So let's start with the ABO blood system.
Actually, I will go to the history of how the ABO blood group system started. And it was discovered by Kehl Lannister in 1900.
Okay.
And he discovered that red blood cells, on the surface of red blood cells, you find antigens which are specific to them. And those antigens have plasmas that produce antibodies. The plasma produces antibodies. too.
Why the
Red blood cells, they have
antigens? Okay.
on their surfaces.
Okay.
So that was like the basics of modern day blood group system and transfusion. That was done in 1900, 1900, yeah. So I'll move on to the genes and how the genes determine the blood group. Like we have different genes in the ABO system. We have for the A group, because there are 4 groups
under the ABO blood group system.
Yes, there are 4 types. Sorry, 4 types under the ABO blood group system. They have the A, the B, the AB, and the O, and they have their genes. Those groups, they can be called phenotypes too.
Okay.
And the genes can be called genotypes too. So those genes, they have the A gene. They have 2 A genes, 1 A gene. For the A group, it has 2 A genes, or A gene and O gene. Then for the B group,
go ahead.
For the B group, you have 2 B genes and B and O gene. That's for the B group. Then for the ABO group, you have just A and B gene. And for the O group, you have O double, as in 2 O's, their genes.
Okay, so you're talking about for these types now, these types under the ABO blood group system,
Yes.
they have each type has a minimum of 2 genes.
Yes, 2 genes.
Okay, that's fine.
So, moving ahead, these genes are present with the ABO, the AB genes are present, and they are the most dominant genes
Okay.
When they are not present, the recessive gene, which is the O gene, becomes present, and that's where you have the group O blood group.
Okay. So you also mentioned, now you just focus majorly on the genes. Then you talked about the antigens and antibodies.
Yes.
These are, you told us how we can spot or identify a type of blood, from the genes,
Yes.
from the genotype. Now, can you tell us how we can identify them with antigens or antibodies?
Okay. The any gene carrying any group carrying the gene A, that group A carries the antigen A. That means it expresses the antigen A on its red blood cells.
Okay.
With that, you can identify that is on the antigen level, that is a group A blood group. With the group B, it carries the B antigen on the red blood cell surface.
Okay.
The group
AB.
the
Group
group
AB.
AB doesn't carries both. Carries both
Okay.
on the antigen surface. Why the O does not
Carry
carry
either of them.
any of them.
Okay. So in the lab, so what's the benefit of, in the lab, how can you identify with antibodies?
With antibodies, there's a test we call Combs test.
Okay.
Yes, that's the test we use to check if the person is producing antibodies in that blood group.
Okay.
Combs test is usually direct or indirect.
Okay, so when is that? But let me get something straight now. For a blood group A, now it carries the gene A and two A genes and antigen A,
Yes.
but it cannot carry antibody A.
Cannot carry
Antibody A.
Yes.
Okay.
I've not talked about the antibodies yet.
Yes, that's what. Yeah, because now we've talked about the genes, we've talked about antigens. Now I want us to talk about the antibodies as it relates to the blood group.
For the antibodies, the group A carries the anti-B antibodies.
Okay, antibodies B.
Yes, antibody B.
Okay.
Then the group B carries the A
Antibody.
antibodies. Then the group
AB
doesn't carry any
Any
antibody. Why the
O.
O carries both A and B. No, it's usually the reverse for the antigen and the antibody. Anyone that carries, if it carries A, it carry B. If it carries
B, it will carry.
A. If it doesn't carry on the antigen, it will carry on the antibody. If it carries on the antibody, it won't carry on the antigen.
Yeah, I think that makes sense because I know I've once upon a time tested I discovered my blood group myself. I tested it myself because I remember that time we were doing a test and there were different antibodies. So they apply different antibodies to your blood.
Yes.
There's the antibody A and there's the antibody B. So
Okay.
when you apply it to the blood, the ones that, for example, if you carry an antibody B now and you apply it on the blood and it's agglutination, I think
Yes,
that's the
it's called
agglutination.
agglutination, clumping of red blood cells.
So if the blood agglutinates with an antibody B, it means that's most likely blood group A.
Yes. No, if it agglutinates with the
But
antibody
the B is most likely a blood
group B.
B?
Yes.
B or A?
Is B. If it agglutinates,
Yeah.
that is a B.
Okay, because it has B antigen.
Yes.
Yeah, makes sense. Oh, yeah. So the antigen and antibodies, they are not in sync. They always.
They are
Yeah,
reversed.
Okay.
They are like vice versa, or like.
Yeah, I think you need to break down this antibody thing for us so we can get
This is like the simplest way I can break it for you.
Okay, the simplest way is that whatsoever blood group, it has the reverse antibody.
Yes. Reverse.
So, but you said for AB now, there's no antibody.
There's no antibody.
Then for O,
O,
for O, first of all, what antigen is in O?
antigen in O. There's
Yes.
no antigen in O.
So it means that there's no antibody in O also. Is that what you're saying?
No, there's antibody.
So which antibody is in O?
It's A and B. A and B.
So if the two antibodies are there, don't they tend to fight or react? I don't know if you get my question.
No, that's when you carry out the the test,
Mm.
that's when you see the reaction.
Okay.
The presence of that antibody
Yeah.
would bring out the reaction.
Okay.
Yes.
Okay. Okay. So away from that now, I know that under this ABO blood group system, we hear terminologies like universal donor, universal recipient. What does that mean, and why are they called that?
Before we move to the
Universal.
universal, that's like compatibility. We have to talk about the Rhesus blood group. We've not talked about it.
Okay, tell me about it.
Okay, the Rhesus blood group. It was a blood group discovered by four individuals.
Okay.
The first person discovered it. First person was Levy and Stetson
Okay.
in 1939.
Okay.
They discovered it in a woman who gave birth to a stillbirth. She and her husband had the same blood group, but after receiving blood from the husband, she started reacting to it. So from there, they discovered that this woman is sensitive. She's a Rhesus negative, while the husband is a Rhesus positive. Then the second person who made the discovery was the same Lannister, Lance Turner, and another person, Winner, in 1940, and they inoculated the blood from a Rhesus monkey into a guinea pig and rabbits, and the Rhesus.
When you say Rhesus monkey, now you mean a monkey that has positive? That's
the monkey's name is Rhesus. That's where the name was coined for.
Oh.
Rhesus monkey from a monkey. That's where it was coined for. That, you know when I said earlier that the Rhesus factor is found in humans and primates.
Yeah.
The primates that I've been referring to are those Rhesus monkeys more of. So the blood from the Rhesus monkey was inoculated into the rabbits and the guinea pigs, and they found out that the Rhesus monkey, the blood of the Rhesus monkey started agglutinating or started forming sensitization in the blood of the guinea pigs and the rabbits. So from there, the term was coined Rhesus factor or the Rhesus blood group.
Okay, so now while you were talking about trying to explain the Rhesus factor, you talked about positive and negative.
Yes.
So when you say someone is Rhesus positive, what does that mean?
It means that, okay, when someone is Rhesus positive, it means that there's an antigen, and that's the most important antigen in the Rhesus blood group system. That's the anti-D antigen.
Okay.
That means the anti-D antigen is present in the individual. But when it's negative, that means the person doesn't have the anti-D antigen. And we still also have antibodies in the Rhesus.
Oh.
We have genes too, but the genes are not, they have a more complex system than the ABO blood group.
So how did this link occur where the antigen D came into can now be present in a blood group A? I don't know if you get my question.
Okay.
Because when you're saying blood group A, it means that the antigen A is present in the person's blood.
Yeah, blood group A.
Yes.
Antigen A.
Yes, antigen A is present.
Yes.
So, but now you're saying Rhesus positive. Yeah. Positive means that there's the antigen D.
Yes, there's an antigen D.
So was it like a crossbreed that brought about this? Or is naturally just
natural, because there are two different blood group systems. So each individual has both of them.
Oh.
Yes, each individual
has both of them. Yes. Okay, so it's not left for you to be either Rhesus positive or Rhesus
negative.
Irrespective of the blood group
you are. Yes.
Oh, makes sense now. So now that you've explained the Rhesus factor, now let's talk about the universal donor or universal recipient.
Okay, in respect to this, universal donor and recipient, has to do with compatibility of blood groups. So the universal recipients are the AB positive individuals.
AB positive.
Yes, AB positive. You know, I said there are actually 8 blood groups according to the ABO blood group system and the Rhesus blood group system.
So please, can you tell us what the 8 blood groups are?
The different blood groups are the A positive, the B positive, the AB positive, and the O positive. Then we have the A negative, the B negative, the AB negative, and the O negative.
So now you're saying universal recipient is the AB positive. Okay.
They receive blood from any
Of the blood groups.
of the blood groups. Then the universal
Donors.
are the O negative.
Wow. So what makes it possible for the AB positive to receive from anybody now? First of all, you said AB, they don't have any antigens.
Yeah, they don't have any
Antibodies rather. They don't have any antibody.
Yes.
So that's why they can receive from anybody.
Yes.
Then the universal donor.
The universal donor, they don't have antigens, but they have antibodies.
Okay.
Them.
Okay. So why can O positive not be a universal donor?
Because of the Rhesus. If you're okay, that's when we'll talk about that later on. But let's finish this aspect
Okay.
of the blood group. For the O that is the universal donor.
You said O negative.
O negative that is the universal donor. They give to anybody. But we have two types of O groups. There's the O positive and the O negative.
Yeah.
O negative gives only to the positive. O positives, they give only to positive blood groups. They don't give to negative. And when you are in blood transfusion, you give the blood group of the first choice of blood group is the person's blood group. And if you are giving other blood groups,
So what that means is, like, for example, as an individual, if I'm B, my blood group is B positive, the
Yes.
first choice is I can receive from a B positive person.
yes, that's your first choice
Okay.
of blood group. But if you are AB, the first choice is B for you.
Really?
Yes.
Why not AB?
Because because in the A blood group has some kind of hemolysis.
What does that mean?
There are substances that lyse the blood.
That
Cause lysis. That's lysis of the blood, destruction of red blood cells.
okay, that's good. Okay,
Yes.
like I
Yes.
get.
So they contain some hemolysis that can make the individual react to
Okay.
the blood. So if even when in the hospital where I practice, if we are giving blood to some individuals and discover that the person is A positive, which is usually the most problematic blood group, we rather give the person an A positive. We start with the A positive blood first. It's only when there's no other A positive to give out, we now give the O positive. And in that O positive,
Give the O positive or O negative.
no, with O positive. We can give O negative too. We go for the O positive because it's cheaper.
Wait, now I'm getting confused because while you were talking about universal donors, you said it was O negative that is the universal donor.
O negative, yes.
But
But I'm talking about the A positive blood group.
yeah, A positive blood group can receive from O positive.
Yes.
Wow.
It's a positive blood group. You can still receive from O negative too.
So are you telling me that O positive is a universal donor for all blood groups that are positive?
Yes.
Okay.
Yes.
But O negative is
for-
irrespective of your resource.
factor, yes.
Oh, no, you're more explicit. Okay. So you're explaining that A positive is the most problematic
Yes.
or complicated blood
Yes.
group.
And why is because they have this like I said,
Hemolysis.
hemolysis in their blood group.
Mm.
So that's why we are very careful with giving them O blood group, O positive blood group for the A positive. Because when you give them the O positive blood, you can exhibit those hemolysis which can react to the blood, which can destroy their red blood cells
Okay.
and causing transfusion reaction and symptoms and the rest.
So the first choice is O positive.
You know? The first choice is the blood group of the individual.
But you said for the A positive.
A positive is A positive.
Oh, so
Or
A
A
is
negative. A negative.
okay. Then before we can. Okay, so now we are already under the risk and compatibility. So you've told us the
Yes.
basic now, which is for every blood group, the first has to be the blood group itself for it to receive from then subsequent. So let's take them one at a time. So we've talked about A positive.
Yeah.
The first option should be A positive.
Then you can give the person
O positive
O positive
or O negative.
Yes.
That works for.
Yes.
Then let's talk about A negative.
A negative takes from only A negative and O negative.
Okay. Then for B positive.
B positive takes from B
Positive.
group O positive.
How about O negative?
You can still take from an O negative.
Okay.
But O negative is like the last choice of blood for us because we usually factor in the cost of the blood.
Okay, that's for the hospital where you practice,
Yes.
not like medically. That's
Not medically.
Okay,
Yes.
but normally, irrespective, as long as the person's resource factor is positive,
Yes.
you can give the person
Negative.
O negative. Okay.
I think it's actually safer than the positive. But if we are looking at cost, we choose the positive.
All right. Then for AB,
AB, they collect from.
that's AB positive now.
Yes, the first choice of blood should be the AB. Where the AB is not positive, where the AB is not available, you can use the group B
Okay.
blood, group B positive. Then before you now talk about the A, because the A's are usually the most problematic blood group.
Okay. So AB positive is the universal recipient. Then AB negative, what can AB negative
Just
receive from?
negative bloods, AB negative and O negative, nothing positive.
Oh, okay. So they can receive from A negative, B negative, AB,
Negative and
O negative. Then for O now, O positive can receive from,
O positive and O negative.
and then O negative can receive from.
Just O negative.
That's it. The major giver now can only receive
From only O negative.
negative.
So once you are O negative, you have to be very careful, especially in females. That's where the risk comes into play for females. Females that tend to get pregnant in the future, or want to get pregnant.
Could that be part of the reason why it is kind of on the expensive side, relatively speaking?
Yes, it's expensive though because it's a rare blood group. It's not the rarest blood group. It's rare. I think the rarest blood group I've ever seen is AB negative because it's very rare. But they can easily take from the O negative. But the O negative must be the O negative.
Okay, so an AB negative can take from A negative, B negative, and
O
A
negative.
negative. Oh. Man, okay. So now that we've talked about that, so we've talked about blood transfusion. So let's talk about blood groups and resource factor in pregnancy. You gave an earlier story, shared an earlier story of how a woman had a stillbirth.
Yes.
So can you be more explicit on that as it relates to pregnancy?
Okay, the risks involved in blood group, ABO blood group and resource factor in pregnancy is usually the woman has to know her blood group prior to pregnancy. As a female, you have to know your blood group because being a negative individual has implication if you have a child that's
Resource negative now.
resource positive.
Okay, I saying being resource. You know when you say negative now, so we have to be specific.
Yes.
Whether it's the ABO negative or the
No.
resource negative.
Irrespective of the ABO grouping, is the resource
Negative.
that determines the incompatibility
Compatibility in pregnancy. Okay.
So it helps to know if you are negative and how you will manage the condition. And the most common incompatibility or risk factor is the resource incompatibility in pregnancy. In a situation where a woman is resource negative and the child is resource positive, having a father that is a resource positive, the woman might give birth to the first child if she has not been exposed to pregnancy before, any sort of pregnancy like ectopic pregnancy, miscarriages or abortion. If she has not been exposed to pregnancy, she might give birth to the first child without having any complications. But after the birth of that child, they have to administer a resource immune globulin injection, which is known as Rogan,
Okay.
to the mother immediately after delivery.
So what does this do?
it helps to it helps the mother not to produce antibodies
Even after the child is out.
Yes, even after the child is out, so that it won't affect her subsequent pregnancies. So, but in a case where the mother has been, maybe she gave birth to the first child and she didn't take that injection, or she didn't know her blood group, she had an abortion or a miscarriage, ectopic pregnancy, then she now has another child, the mother will produce antibodies. And when she starts, she might not have started producing antibodies, but maybe she has already been exposed to it. In a situation where she has not been exposed to it, the antibodies, she has not started producing antibodies, and she had pregnancy prior to that time, she would carry out the antibody test. That's where I talked about the Combs test. She would carry it out in the first trimester, the 28th week of pregnancy, and during the delivery.
Okay.
But if while she's carrying out those tests, if she discovers that it hasn't crossed, she can still take the injection while being pregnant. But if the antibodies have started producing and start crossing to the baby, then there's nothing that can be done.
So in this complication, who is at risk of losing their lives? The mother or the child?
The child.
The child.
Yes. And when the child is born, the child can be exposed to conditions like severe jaundice, erythroblastosis fetalis, which is also known as hemolytic disease of the newborn, fetal pneumonia, and excessive production of bilirubin and other complications happen to the child. But if they discover that the child is having these conditions immediately after birth, then they will have to do a blood transfusion for the baby. Like they call it exchange blood transfusion. They have to exchange the baby's blood.
Wait, I don't understand. So if the child's natural blood group is, let's say, A positive, so you change it to B positive or what? Or A negative?
You still give the child the blood group that is.
It has, but you just have to neutralize it with the additional blood.
Yes.
Okay, so now you mentioned, is it the Rogan injection? So if you give it to a mother once, does that solve further complications, or after each birth the mother has to take the injection?
After each birth of her child, she has to, it's a normal thing, she has to take it immediately after delivery. As
long as she's negative, Rhesus negative.
Yes.
Okay, so now even as we begin to wind down, can we talk about the benefits of knowing your blood group and Rhesus factor, the benefits?
The benefits of knowing your blood group and Rhesus factors, I will just talk about very few. They're actually not that much. Number one is to prevent incompatible being transfused and incompatible blood. Oh, I didn't even talk about the risks involved in incompatibility.
Okay, so tell us
adults.
Yeah, tell us about the risk before.
The risks involved in incompatibility in adults are not so extreme, unlike when it's a mother to child. And most times the incompatibility is it's caused by human error.
So when you talk about incompatibility, like in an accident situation and blood transfusion, and somebody is A positive and give the person a B blood group, so what's the risk of that?
The risk, person might just show like reactions like maybe develop nausea, difficulty in breathing, muscle ache.
Can't it lead to death?
If it becomes too extreme, they will have to take the person to the ICU.
But if it's spotted in time,
then the person would. There's a remedy. Maybe they will have to give the person a saline treatment, like the normal saline that they give. Treatment for the person.
Okay, so now, we can go back to the benefits, right?
Benefits, yes. So the benefits of knowing your blood group involves in case of emergency, like you need a blood transfusion. Knowing your blood group will go a long way in helping out. Even though before they transfuse the person, we still have to carry out the blood group test. But we have an idea that this person already knows his blood group or her.
So that's the first blood group you test for?
Yes, blood group test for the blood group when you are giving her blood. Then it helps to know what kind of donor you are. If you want, in terms of when you want to donate blood, helps to know what, if you're a universal donor, if you're a universal recipient, if you can give blood and the rest. Then it also helps to plan a healthy pregnancy. Like a woman that is negative, she would know that, okay, before I get pregnant, these are the steps or things I need to do before I have my child. Then it helps to mitigate health conditions.
Okay, so now let's talk about the pregnancy and the health conditions very quickly. So a mother that knows that she is a Rhesus negative, and maybe do you test for the blood group of a child while the child is still in the womb?
Yes, there's a test.
So if you spot that the child is Rhesus positive, what do you do with that mom? You give the mom the Rogan injection immediately?
Yes, you give her the injection if she has not started producing antibodies.
But if she has, what's the remedy?
There's nothing you can do. You just allow her, monitor the pregnancy.
And there's a risk of losing the child.
Yes, there's a risk.
So you just let...
Yes, you let it be. Because she has already started producing antibodies. If she hadn't started producing the antibodies initially, you could have given her the Rogan injection while she's still pregnant. So
does it mean that if you administer the Rogan injection while she's already producing antibodies, it puts her life at risk?
It won't do anything. It's not going to do anything.
Okay, I see. So sorry, let's go back to the benefits. So you talk about it reduces health conditions, healthy pregnancy,
yes,
and easy transfusion. So
and it helps to know how rare your blood group is. Like the O negative.
Alright, if you're O negative and you're watching this, she's not here to scare you. It's just knowledge so that you know.
As an O negative individual, it's not as bad as before, where it's very difficult for you to know to get donors. Now it's actually more easier from my practice so far. It's easier to get O negative donors if you are in a life-threatening condition. So if you are O negative, please don't be scared.
All right, thank you very much, Sophia, for your time. Before you leave, do you have any medical advice you would like to leave with the viewers?
Well, my medical advice is for my practice so far, I've noticed that most Africans don't care about their health status. They don't do medical checkups. In fact, they use the blood of Jesus to cover themselves. And when they come to the hospital, you see that most of them are predisposed to some diseases that are already exposing us as Africans to them. And most of them are usually high blood pressure and diabetes. You can see a young individual maybe in their 20s having a blood pressure of almost 200, 150, and it's because of stress. And you know how stressful our country is and this part of the world is. So it predisposes us to hypertension. So we should, even as a young person, you should go for regular checkups in a year, at least 2 times in the year. But that will help extend your lifespan.
All right, thank you very much, medical lab scientist Sophia Ubede of St. Luke's Hospital, Asaba. Really appreciate your time. All right, that's all we'll be taking on today's episode of Health Talk. I hope and I believe you've learned a thing or two. Until next time, do well to know your blood group and resource factor and stay healthy.